We are thankful to Dr. Vijay Kumar Chopra sir for giving us this talk on this inaugural webinar of 2026, and we are also thankful to all of our eminent panelists, expert panelists who have found time to join us, Dr. Mutan sir, Dr. Subbarao sir, Bahal sir, and Dr. Ajay Swami sir. And so we have chosen, Dr. Chopra sir has chosen to speak about the main trials of 2025, which are trending or practice changing in that sense. So over to you, sir. Thank you so much once again. Yes.
Thank you, Sojatya. So what I thought was I would like to keep the format this way. I've chosen 10 trials, and
Sir.
these trials have been chosen based upon the late-breaking trials in ESC, um, in ACC, European Society of Heart Failure, and Heart Failure Society of America. There were a number of very, very interesting trials. So it is quite possible that I have left out some of the trials which others would have found more interesting. But I mean, in the limited time, this is what I have. I have also tried to choose trials which have been published in New England Journal of Medicine because I think that is one of the benchmarks of it being a trial which has got practice changing potential. So with that, let's start. And what I would request is that I will present 4 or 5 slides for each trial. And then I would like to stop and take the opinion of eminent panelists. Okay. So with that, I'm going to share my slides. Okay. Can you see my slides?
Yeah. Yes, sir.
And that's full screen. And how do I remove this? Okay. How do I get this side screen off? Can you remove the side panel? Because okay, there are too many things appearing on that. Is it possible to
So
remove
the
the side
slides are
panel?
clear. The slides are very clear.
I know, but I just want to remove the side. Okay, fine. Okay, so let's see. These are the 10 trials I've chosen. As I said, that they may not be the ones that everybody likes, but these are the ones which I thought were very provocative. So let me start in no particular order of importance, but at random. In ESC Congress 25 and ACC, these two hotline trials were presented called BAX HTN and Cardia. Sorry, I'm still trying to get this side panel off somehow or the other because it's interfering with my slides.
Netcast, can you help, please?
You know, this side panel in which our names are appearing, I would like that to be away. I'm so sorry about it.
So the side panel is not there in our in what we are seeing. Maybe it's there in
I
yours.
think, I mean, the problem is mine. It's not.
You can see all the what top 10 trials in cardiology.
Let me share it once again. I'm sorry. Just hold on. Please bear with me. Let me just log off and start again. Hello, Netcast service. Can you please help me? I can only see the panel of the speakers and panelists. No?
You have your laptops.
Sorry?
Hello.
You have your laptop in front of you.
Yeah,
Sir, we
Oh.
saw your slide once. The
I know, but after
backside
that,
HTN.
after that, it has gone into a panel of showing everybody's face
Oh.
rather than the
Sir,
screen.
I think you can stop sharing and reshare.
Okay,
That will bring the screen again back display.
okay.
Screen sharing is already stopped, so you shared the screen again.
Okay.
Or if you can disconnect and rejoin again. Sir, can you hear me?
I can hear you, but I don't see my slides. They're disappeared.
Sir, presentation might be in your that folder where you saved.
Sorry?
Sir, where you save your presentation,
Yes.
you just open it.
Sir, is it still not working?
Okay.
Yes.
That's okay. So sorry about it. Okay, so these two hotline trials were presented at ESC Congress and at ACC, which explored treatment options of patients with uncontrolled hypertension. So this was published, Baxdrostat in uncontrolled hypertension or resistant hypertension was published in NEJM also. So we know aldosterone dysregulation is a key driver for hypertension and end organ damage. MRAs can block mineralocorticoid receptor mediated effects of aldosterone, but their clinical utility is limited because of dose dependent adverse effects and aldosterone escape. Now, what is Baxdrostat? It's an aldosterone synthase inhibitor. Aldosterone synthase is the only enzyme which synthesizes aldosterone by whichever pathway. So if you inhibit that, it follows logically that you will have a more upstream inhibition. Uh, this is a very exciting. These are a very exciting set of molecules. The problem till now has been that aldosterone synthase inhibitors have a 95% similarity with the enzyme which synthesizes cortisol. And therefore, when they tried to inhibit aldosterone synthesis, there was a major reduction in cortisol production also. But now these are two molecules, Baxdrostat and Vicardrostat. Both have shown 100 to 1 selectivity in inhibiting aldosterone inhibition without affecting cortisol synthesis. Number of trials going on now with this, not only in hypertension but in heart failure space also. There are two trials going on with Vicardrostat, which is another aldosterone synthase inhibitor, in combination with the empagliflozin, one in heart failure with reduced ejection fraction and one in heart failure with preserved ejection fraction. Another trial is going on with Baxdrostat in combination with dapagliflozin in prevention of heart failure in high-risk individuals. So that is apart from this. So we are participating in all these trials, extremely exciting. So let us see. So, but anyway, HTN phase 3 trial, the objective was to assess the efficacy and safety of Baxdrostat in patients with uncontrolled or resistant hypertension. More than 18 years of age, mean systolic blood pressure more than 140 to 170. And despite treatment with maximally tolerated doses of 2, which is uncontrolled, or 3 antihypertensive drugs, that is resistant, including a diuretics for 4 weeks before screening. EGFR had to be more than 45 and serum potassium between 3.5 to 5. Obviously, they excluded current use of MRAs, secondary hypertension, uncontrolled diabetes, and atrial fibrillation or acute cardiovascular events. The primary endpoint was change in seated office systolic blood pressure from baseline to week 12 with 98% power to detect a mean standard difference of 6 millimeter change from a baseline to seated blood pressure. And there were a number of secondary endpoints, including exploratory secondary endpoints of serum aldosterone concentration and plasma renin activity, and also mean 24 hours and nighttime ambulatory blood pressure. So that was the format of the trial. So out of nearly 2,600 patients, ultimately they ended up by randomizing about 700 patients in placebo or in baxdrostat 1 milligram or 2 milligrams. And what they found, this is the primary outcome, that seated blood pressure showed a mean of 8.7% reduction in seated systolic blood pressure with 1 milligram and nearly 9 milligram with 2 milligrams. Impact on serum aldosterone concentrations also you can see was very significant, with a major drop of 60% with 1 milligram and 65% with 2 milligrams. And in a double blind, when they stopped the treatment, you can see that aldosterone levels stayed down with baxdrostat, those who were on baxdrostat, but those who were on placebo, they gradually started rising, indicating that it's got a long duration of action. So the conclusion was, in patients with uncontrolled or resistant hypertension, the addition of baxdrostat 1 milligram or 2 milligram once daily led to a reduction of 8 millimeters and 9 millimeters after 12 weeks. It was consistent across all specified subgroups and persistent for 32 weeks at least. Ambulatory 24 hours and nighttime systolic blood pressures were reduced substantially, generally well tolerated. Potassium more than 6 were low, both in baxdrostat and in placebo group. The other trial in the same genre is Cardia 3, which is zilebesiran as an add-on therapy in adults with hypertension who have established cardiovascular risk or are at a high risk for cardiovascular disease. So zilebesiran again is a lot of work done on it. It's an investigational RNA interference therapeutic molecule. We know that we are gradually moving into more and more targeted therapies where you try to focus only on the basic mechanism and thereby avoiding a lot of side effects which occur. So what this does is it goes even more upstream. It reduces hepatic production of angiotensinogen, the most upstream precursors in RAS pathways, and has the potential to provide continuous BP control of blood pressure with subcutaneous dosing every 6 months. Two trials had already been done, Cardia 1 and Cardia 2. One was for safety study and second was a further elucidation of that. This was Cardia 3 study. So this was done in 5 countries, uncontrolled hypertension, already prescribed 2 to 4 antihypertensive drugs. And they gave, if EGFR was more than 45, they gave 300 up titrated to 600. If it was less than that, they gave 150 up titrated to 300 and 600 in some people. And then after 3 months, antihypertensive intensification was permitted. The primary endpoint was changed from baseline to later on office systolic blood pressure with a number of secondary endpoints. What we find here with zilebesiran is that over a placebo, there's a 5 millimeters reduction with 300 milligram and about 10 milligram, almost equal or a little less with 600 milligram, not much of a difference. And this is the hourly mean exploratory change from baseline in daytime and nighttime ambulatory blood pressure. You can see that there's a healthy dip in nighttime blood pressure with zilebesiran. Based on this, a phase 3, so this is only a demonstration of the blood pressure reduction, but ultimately what happens is what are the CV outcomes. So this trial is being planned now in cardiovascular outcomes with the primary outcome of CV death, non-fatal MI, stroke or heart failure events with a minimum placebo for minimum follow-up of 2 years. So the conclusions of cardiac trials were among individuals with cardiovascular disease or risk factor, a single dose of zilebesiran 300 or 600 led to a reduction in BP at 3 months. However, statistical significance was not reached. Those on diuretic therapy may experience a greater BP lowering. It demonstrated an acceptable safety profile, and Zenith trial will evaluate its impact on CV outcomes. So these were the two trials which made a lot of noise in these meetings for uncontrolled hypertension. So with that, I'll stop here and take the opinion of our learned colleagues for these two trials.
So in the first trial, how many patients had primary aldosteronism? Did they report that?
No, it has not been done in primary aldosteronism yet.
That was one of my questions also.
It has not yet been done. There's a separate trial which is ongoing for primary aldosteronism.
So because if we are going in for personalized medicine, that one drug for a particular hypertensive, then we'll have to probably go in for subgroups.
Correct, Ajay, but that trial is on, so these are all, new thoughts, new ideas, they are being explored. I mean, zilebesiran didn't even reach statistical significance, but it is exciting to see that you can use one drug, one injection, and sort it out for 6 months, much like inclisiran for LDL. So I think these are new things which are being explored. Any other?
What any
Any
side
other?
effects of Addison's disease, anything like hypocortisolism in any such patients?
So these are the trials which are there at present. Basically they have been done. These are, as I said, they are being explored. They have started with hypertension. Now they are going on to management of heart failure with aldosterone synthase inhibitors and also prevention of heart failure. The aldosterone synthase, which is vicadrostat, that Javed Butler is doing 2 trials with preserved and reduced, and prevention of heart failure with dapagliflozin, John McMurray is doing. So we are participating in all 3 trials, and they are very, very interesting. The trials are enrolling very fast, so we should be getting results pretty quickly.
Sir, is there any advantage over spironolactone?
Well,
It's a much more upstream inhibition. It's a much more upstream inhibition. So the problem with aldosterone, as we know, is aldosterone escape, and there are alternative pathways present. So if you can stop the synthesis of aldosterone right at the beginning, see, the only enzyme which synthesizes aldosterone is aldosterone synthase. So if you block that, then whatever be the pathway, it doesn't matter.
Is there any difference in the cost?
In the
Cost?
It is not in the market yet, sir.
What is the expected cost, sir? Will it be
I
much
don't know.
more higher than aldosterone inhibitors?
I have no idea. I don't think this is a forum to discuss that. Let's stick to science and what it shows. So can I go to the next one?
Yes, sir.
Okay, so next is again a very interesting trial, which all of you, I'm sure, have read about it. This is Digit HF. All of us have been using digoxin in heart failure for donkey's years till the DIG trial came and poured a lot of cold water over the use of digoxin. However, most of us still continues to use digoxin in patients who had severe heart failure, recurrent admissions, atrial fibrillation, and so on and so forth. So this is Digit HF, which was reported in New England Journal of Medicine last year. Multi-center randomized double-blind placebo-controlled trial, 1,200 patients equally divided in digitoxin they used and placebo. Median follow-up of 36 months with a primary outcome of death or first hospitalizations for heart failure. 66 average age, 20% women. This is the disposition of NYHA class. EF was average 29%, ischemia 52%, heart rate, systolic blood pressure, EF, etc. You can see. Extremely well treated on the background. Beta blockers 95%, ACE, ARB, ARNI together about 94%. MRA is also significant. SGLT2 inhibitors 19%. Primary outcome was death or first heart failure hospitalization. and that was 39.5% versus 44%, with the narrow confidence interval hazard ratio of 0.82. So that was significant. Secondary outcome in mortality, it was 27 and 29, hazard ratio 0.86, but the confidence intervals cross the line of unity. First hospitalization for worsening of heart failure, again you can see the data, and death from any cause and all heart failure hospitalizations, hazard ratio was 0.85. Subgroup analysis showed that the primary outcome comparison, it was similar across all subgroups, including age, sex, NYHA class, atrial fibrillation, systolic blood pressure, BMI, hypertension, diabetes, EGFR, ICDs, CRT, MRAs, ARNI, triple therapy, quadruple therapy. So all the subgroups which are analyzed, they had showed benefit. Adverse events, SAE 4.7% in digitoxin and 2.8% in placebo. Discontinuation rate almost similar. The criticism was it did not achieve goal enrollment, so it is underpowered for primary outcome. So although an effect was beneficial effect was detected, the estimate has limited precision, which is called the winner's curse. It is unclear whether study findings will apply to digoxin also. Background GDMT was dependent upon treating physicians and varied by class. The question is why digitoxin? Digitoxin is hepatically metabolized, so is safe in renal dysfunction, more stable across plasma concentration. It's got a long half-life, so levels are steady. Digoxin is renally cleared, half-life is 36 to 48 hours. So that was Digit trial. I think there's a lot of interest back in Digitalis. So let's see. What do you think?
Yes, sir, I think we read too much into the ditch trial, because in the ditch trial, the dose of digoxin was very high. The dose used was around, it went up to zero point 0.5 milligram per day. So we never use zero point 0.5. We use 0.1 to 5 is the usual dose. And even when we look at the analysis of the ditch trial, the increase in arrhythmias was only seen in patients whose level was more than 1.1.
Right.
So in patients whose level was less than 0.7, in fact, the arrhythmias were reduced. And levels zero point 0.7 to 1.1, the risk of arrhythmias was not increased. It was neither increased nor reduced. The problem was, I think, in the ditch trial, the dose of digoxin was very high. So nowadays we are normally using half the dose. So probably it should be safe.
I've been using digoxin actually. In
Yes.
all patients with heart failure with atrial fibrillation, but not without atrial. I don't know whether that's correct, because it seems to be better in patients with atrial fibrillation rather than in sinus rhythm.
So I don't think most of us stopped digoxin. In selected patients, all of us kept on using this. Oh.
Irrespective of the rhythm, should the rhythm be atrial fibrillation or even in sinus rhythm it works?
Yeah.
Sometimes digoxin works when nothing else is working. It gives symptomatic relief.
Yeah.
Okay. So
sorry, I don't understand.
hello?
Yes, sir, we can hear.
Yes.
I think I got there's something funny going on.
So we can see your mouse hovering over the slides.
I know. Okay. Where are the slides? But this
Just have to put the arrow mark somewhere.
audio, video, participants, chat, share, pause, layout. Okay. I don't know. It's never happened like this. Somehow or the other, it had to happen with my PGI meeting.
Sir, is digitoxin available in the market, sir?
No. It's only some companies producing it. It's available in these Germany, etc. These countries where they did this trial. It's not available elsewhere.
What about Obain? Obain was supposed to be given IV and all that during our MDA program.
Yeah. Okay, fellows. I still can't. Can you see my slides?
Yeah, I can use. Not on the next one.
Slides are seeing, sir, but you have to go to the next slide. Slides are seen. You can press enter and go to the next slide.
Yeah, but I can't see. It's suddenly disappeared.
Okay. Relog in then.
Slides are seen here, sir.
Sir, I agree, but I can't see, unless I see how.
You can maximize that slide again. Maximize.
Sir, try pressing Alt with Tab.
Sorry?
Alt with Tab. Alt and Tab. That will move you through different windows that are open.
Alt. On Mac, there
Alt
is
and
no
Tab.
Alt.
Both are on the left side, sir.
On Mac, there's no Alt.
Then there will be CMD. And try pressing Tab alone, sir. कितना तेज आ रहा है.
I'm so sorry about this.
Sir, the command and tab is same as alt and tab.
Command and tab. Tab is what?
TAB, sir. There is a button usually on the keyboard on the left side. Third from the top and fourth from the bottom.
Yeah.
Then this scrolls you through different windows which are open.
Can you see now?
No.
Same screen here, sir.
Okay.
Same slide. Now we can see.
Okay, fine. Sorry. So this we are done. Now I think it's okay. Okay. Next is Surpass CVOT. Now again, we have been hearing a lot about it. This is cardiovascular outcomes with tirzepatide versus dulaglutide in type 2 diabetes. Again, this was printed in NEJM last year. It's a double-blind non-inferiority trial in type 2 diabetes and atherosclerotic cardiovascular disease in 13,000 patients. The primary endpoint was a composite of CV death, MI, and stroke. The primary endpoint event occurred in 800 patients, 12.2% in tirzepatide and 13% in dulaglutide group, hazard ratio of 0.92, confidence interval 0.83 to 1.01, p 0.003 for non-inferiority. So basically, it was a non-inferiority trial that they wanted to demonstrate. It also had 0.09% for superiority. And these are the slides these are the results. If you see on the left-hand top, cumulative incidence of death from CV causes myocardial infarction or stroke, dulaglutide and tirzepatide are shown here. Hazard ratio is 0.92 with the confidence interval with just about crosses the line of unity. Death from CV causes, again, small difference. Myocardial infarction, 357 events versus 311 events. This guy. And stroke, present in 249 versus 229. The change in glycated, so these were almost identical, not much of a difference, but change in glycated hemoglobin at 36 months was much more with tirzepatide as compared to dulaglutide, and the change in body weight at 36 months was also more. Safety and discontinuation, overall safety, total adverse event rate were similar, nearly 32% serious ASAEs. GE tolerability dominated, it was nausea and diarrhea. These were the most common. Discontinuation rate was also nearly equal. The conclusion was a pre-specified secondary analysis suggested a possible lower incidence of death from any cause and death from non-CV causes in tirzepatide group than in dulaglutide group. This is exploratory findings. Among patients with type 2 diabetes and ASCVD, it was non-inferior to dulaglutide with respect to composite of CV, death, MI, and stroke. So basically, they wanted to demonstrate that the weight reduction is more and the events are non-inferior to dulaglutide. Comments? Hello?
Yeah, yeah.
These days we're seeing a lot of these SGLT2 inhibitors.
Sorry?
So these days there's a lot of discussion about semaglutide and
Tirzepatide, yeah.
obesity treatment. So one of the side effects that I mentioned is depression, suicidal ideation, self-harm and all that.
Yeah, but suicidal tendencies, subsequently the trials which they did, they found that there's no difference. It is more of an initial impression, but then subsequent detailed analysis that has not been documented.
So probably what this suggests is that in obese patients with diabetes, this can be used, but it doesn't have much effect on cardiovascular events. Can we conclude that from this trial?
So, the effect on cardiovascular diseases is much more shown much more with semaglutide rather than tirzepatide. But their CV outcome trials are also going on. They'll come out in 6 months. I'm sure that will also be positive. One can say there's no reason why it should not be positive, but till we get the data, we don't know. Till now, weight reduction is more with tirzepatide, but CV outcomes are better with semaglutide as the data stands today.
I think they had expected a 16% reduction in MACE, but got only 8% reduction. So is that maybe a underpowering issue here?
So this was basically not powered enough to demonstrate cardiovascular outcomes. That trial is going on, and the results are expected in about 6 months' time. So I think later this year or early next year you will see those. Okay, so let's go on. Quite a few more to go. So next is Vesalius CV trial, short one, evolocumab in patients without a previous MI or stroke. Again, published first in last year, and then a summary of it was presented this year. So they took 12,000 patients stable at high risk for CV events, but no prior MI or stroke. And LDL had to be more than 90 or non-HDL more than 120 or ApoB more than 80. And they were randomized to receive evolocumab or placebo. Event-driven trial, mean follow-up 4 years, and every 4 months there was a follow-up. It included CAD without MI, CVD without stroke, peripheral artery disease, advanced diabetes. And the primary endpoints were as listed here: time to CST, death, MI, ischemic stroke, time to CST, death, MI, ischemic stroke, or revascularization. So the trial was significantly positive with a hazard ratio of 0.75, narrow confidence interval, and p.001, indicating the benefit of evolocumab in this group of individuals. So the key outcomes was the trial met its dual primary endpoint over a median follow-up of 4.5 years, 3-point MACE 25% risk reduction, 4-point MACE 19% risk reduction, which included ischemia-driven arterial revascularization, MI reduced by 36%, LDL reduced by 55% at 48 weeks. Mortality was a 20% reduction in all-cause death, but it was not statistically significant under the trial's hierarchical testing structure. So this was the Vesalius trial. Again, something very interesting. I don't know whether it's going to enter the therapeutic armamentarium or not. What do you guys think?
It's an injectable drug, sir. The MAB.
Yes, evolocumab is a monoclonal antibody.
This will really expand the indication of the drug, because here now we are going in for high risk individuals whose LDL is just above 90.
Yeah. And they don't have MI or stroke. So more like a preventive strategy.
Preventive.
Okay, shall we go on?
Right.
Okay.
Yes.
So next is Victor trial. We are all familiar with the Victoria trial, where vericiguat demonstrated a significant effect in worsening of heart failure in patients who were already on guideline-directed medical therapy. But there's always been a question, what will the drug be useful in patients with stable coronary artery disease also? Off-label, many of us have been using in patients with heart failure without a recent worsening. So this was again published in 2025, last year. The 20 publication is for Victoria. So objective was to assess the effect of vericiguat on the risk of composite endpoint of CV death and heart failure hospitalization in ambulatory patients with HFrEF without a recent worsening. So they took patients with HFrEF, no recent heart hospitalization for 6 months, and no IV diuretics for 3 months, anti-proBNP 6,000 to 6,000, 600 to 6,000 based upon the Victoria results. No recent change in GDMT. Primary endpoint was CV death or first heart failure hospitalization, and there were a number of secondary endpoint, including secondary powered endpoint was CV death. 6,000 patients, 95% power for CV death or hospitalization, 80% power for CV death. The primary outcome of composite did not reach statistical significance, although it was numerically significant. But extremely interesting points came out. Look at this. CV death reduced by 17% with the narrow confidence interval statistically significant. All cause death against statistically significant. Sudden cardiac death significantly positive. Heart failure related deaths. So all components of whichever form of death was there turned out to be statistically significant. But if you took heart failure hospitalizations, there was no difference. The lines are almost overlapping with each other. So this was an extremely interesting finding. So I was there at the presentation. This was presented by Fayaz, and John McMurray gave a commentary, and he said, this trial is totally different from anything else we have seen. Have we ever seen a reduction in mortality without reduction in heart failure or hospitalization? Second, he said, how will you reduce death but not heart failure hospitalization? Third, he said that why would the effect not be there with vericiguat in anti-proBNP over 8,000, as we saw in the consensus trial? Because in consensus trial also there were patients of class 3 and 4, and there was benefit with that class of drugs. So there were a number of very interesting points. And he said, I don't have any answers, but we need to dive deeper into this. The conclusions of the trial was vericiguat did not reduce the risk of primary endpoint, which is a composite of CV death or heart failure hospitalization in ambulatory patients with HFrEF on a background of high use of contemporary GDMT. In pre-specified powered secondary analysis, CV death was significantly reduced. In exploratory analysis of all-cause death, sudden death, and death due to HF, numerical reductions were evident in vericiguat versus placebo. Although it did not reach statistical significance, the totality of evidence still suggests a favorable effect of vericiguat on compensated outpatients with heart failure with reduced ejection fraction. Subsequently, Javed Butler gave a commentary on that. And he said that if you take patients who have not had a recent worsening of heart failure, it is likely that they will die of sudden cardiac death, as we saw in Paradigm trial. In class 2, there was a significant benefit in sudden cardiac death. There was hardly any heart failure hospitalization in class 2 patients. So something similar. And second, he said was that these patients had an excellent background therapy and they were reasonably stable. So one would not have expected so much of a heart failure hospitalization. So, but anyway, intriguing results. And I don't know. What do you people think? Comments?
So what was the death rate? I mean, in both the placebo and the vericiguat group, was it more than expected, or?
This is what it is.
Yes. So it was
Incidence rate.
around 15.
Yeah.
So around
15%
15% patients died over 2.5 years.
Yeah. And that is in stable heart failure without a recent hospitalization, without IV diuretic in the previous 3 months.
So that is the usual rate of deaths, maybe
Yes.
around 5% per year or something.
Yeah.
So,
So, very intriguing results, but this is what it is. Are you people using vericiguat in stable heart failure patients? If another drug cannot be used, another GDMT cannot be used.
Sir, if creatinine is
yes, sir.
high, then we can use or are using sometimes. I am sometimes using in dialysis patients also.
Dialysis patient, less than 15% of EGFR, there is no evidence of vericiguat being effective. Neither is there any data on dialysis patients in vericiguat patients.
What is the explanation for the reduction in mortality without a reduction in hospital admission for heart failure?
But this data, this trial is for stable heart failure patients where there was no recent hospitalization.
Sir,
So that way it was different than the previous Victoria trial.
sir, is this like a newer and safer digoxin, sir?
Sorry?
Newer and safer digoxin? This
I
trial
don't
is.
know. That is for each one of us to decide. I mean, how can, I don't know. It's a totally different mechanism of action, than vericiguat, than digoxin.
So, what is the graph of heart failure hospitalization? Have they given the no?
Here it is.
Yeah, heart
Heart
failure.
failure hospitalization
Yeah, this is almost the same.
overlapping each other.
Overlapping. So the mortality and heart failure hospitalization is almost the same. So it's a 15% heart failure hospitalization and a 15% mortality.
Correct. But mortality was benefited, not heart failure
Not
hospitalization.
yes.
So that's what McMurray said. Have we ever seen this in any other trial? No.
Very odd.
Okay.
Yes.
So let's go on. So I thought all these were very, very interesting trials. They make us think and teach us something. So next, let's switch to hypertrophic cardiomyopathy. Ajay Behel, your field. So maple HCM, I'm sure Ajay will give us his comments on that. So this is aficamten or metoprolol monotherapy for obstructive hypertrophic cardiomyopathy, published in 25. The discussion on this was led by Carolyn Ho. So I will show you the discussion slides because she discussed both Odyssey and Maple HCM. Extremely good discussion. So clinical trials of myosin inhibitors versus placebo have been successful for obstructive cardiomyopathy. We have seen this in Explorer, Valor, and Sequoia. They all were useful. Maple HCM challenges the status quo. How good is a traditional first-line therapy which we have been relying on, which is beta blockers? So now, if you look at the left side panel, mean PVO2 with beta blockers in red, it kept on decreasing while it increased with aficamten. On the right hand side, you will find change in PVO2, aficamten with placebo. There also it improved. Of course, it was against placebo. But in Maple, they found that with metoprolol, your PVO2 kept on decreasing. How good is a traditional therapy? So, if you take Valsalva LVOT gradient in Maple, there was a significant drop. And once they stopped the therapy, which is on the gray in a washout period, it quickly caught up with that, indicating that there was a true effect, a beneficial effect on LVOT gradient when they were in aficamten. In Sequoia, also you saw that the gradient with aficamten compared to placebo was significantly better, but after washout, it caught up with it. As far as KCCQ score is concerned, again, there was a benefit as compared to metoprolol, and after washout, it caught up with that. And same thing we saw aficamten with placebo, that there was a benefit. So what they tried to show was that both LVOT gradient and KCCQ scores, they were better till they were on aficamten as compared to metoprolol. And indeed, the PVO2 was also better. So the question raised by Odyssey about CMIs for non-obstructive cardiomyopathy, are they well tolerated? Higher proportion of non-obstructive cardiomyopathies experience decrease in EF, heart failure, and withdrew from therapy. So you can see Odyssey HCM, LVF less than 50%, 21.5, less than 30%, 2.5, heart failure 19, withdrew from therapy 1.9, discontinued therapy 8.3%. As compared to right side explorer SCM with obstructive cardiomyopathy, results are much better. Heart failure only 1.6%, hardly anybody withdrew from study. So, do we know the right dose? Odyssey titrations were based on preserving LVEF rather than reducing gradient. Target doses in non-obstructive cardiomyopathy were based on maximally tolerated dose. Up titration if EF was more than 65%, while in obstructive hypertrophic cardiomyopathy, they used the minimal effective dose in resolving obstruction. So she concluded by saying that beware when standard of care evolves out of practice rather than evidence. Challenging the status quo is needed for progress in medicine. Beta blockers may not provide meaningful benefit in obstructive hypertrophic cardiomyopathy and may not be well tolerated as we have been believing. Evidence is now available to consider using cardiac myosin inhibitors as first-line therapy, but practical implications will require easier initiation and maintenance of therapy and payer support given the cost of this therapy. So, is there a future for CMIs in non-obstructive hypertrophic cardiomyopathy? Perhaps, but we need to learn more. Obstructive cardiomyopathy is relatively straightforward. Non-obstructive cardiomyopathy is more complex and heterogeneous. So, can we identify physiologically relevant subgroups who will benefit from CMI? Is it hyperdynamic patients? Is it mid-cavity obstruction? And on the right-hand side, as I've written, do we know what drives symptoms in non-obstructive? Can CMIs improve relaxation and energetics at pharmacological dose, or is their benefit predominantly due to relief of LV obstruction only? So, Acacia HCM is in progress. Top line results are expected a little bit later in this year. So, I thought extremely intriguing and interesting trial. We have been believing in beta blockers, but here is something which tells us that what we have been doing may not be the best. Ajay, can I take your comments? Because I think you
Yes, sir.
know more about this than anybody
Sir.
else.
So there is a problem with beta blockers in hypertrophic cardiomyopathy because once a person exercises, the beta blockers produce a chronotropic incompetence. So the heart rate doesn't go up proportionately. The problem in HCM is that the ventricle is small. So the stroke volume is small.
Correct.
So a person is very dependent on the heart rate to increase the cardiac output. So this is a problem with beta blockers, and probably drugs like aficamten and mavacamten, maybe we can use them even without beta blockers. Earlier, the problem was that diisopyramide cannot be used without beta blockers because diisopyramide, it increases the AV conduction. So in case a person develops atrial fibrillation, he'll develop a very fast ventricular rate which can degenerate into atrial fibrillation. But these drugs, possibly, we may be able to use them without a beta blocker.
But Ajay, what is your opinion about non-obstructive hypertrophic cardiomyopathy? That's why I brought this slide back. It doesn't seem to work in them. In fact, it
Yes,
makes it worse.
yes, so probably the effect is on LVOTO only. Non-obstructive HCM is a very different disease. The contractility is not so good. A good number of patients, I think the mean LVEF between non-obstructive and obstructive will be very different. Non-obstructive will be
Ajay, if we
closer to
forget
50.
about mean LVF, what about
Yes.
people who have preserved LVF or supernormal LVF, but they have non-obstructive cardiomyopathy? Given the fact that it relaxes the heart muscle, should it not be helpful in them also?
Sir, it may not be, sir. I don't know. Difficult
We
to
don't
say
know.
because yes, sir, because the pathophysiology may be much more complex.
Okay.
Another question will be that let us suppose we use these drugs over a period of years, 4 5 years, then do they remodel the heart? That maybe if we are able to stop these drugs or reduce the dose, will the obstruction go away for good? That also is something that we need to see in the future.
But this is what that is. Look at this slide. At least, of course, it's short, only 2 years.
Yes.
After
Yes.
2 years, when they stopped the drug, it went up again.
It went up again. But only thing is that the hemodynamics, that is the obstruction, is also probably contributing to some extent to the hypertrophy. For example, when we do a myectomy or alcohol septal ablation, the thickness of the rest of the ventricle also goes down over a period of years. So what we need to see is that let us see over 5 years or 10 years whether the wall thickness goes down and the obstruction reduces.
Ajay,
That is
could be
something
that
which only time will tell.
yeah, is a possibility there's a dual problem. Because of the obstruction, there's a secondary hypertrophy of the
Yes.
rest of the ventricle. So once you
Yes.
relieve an obstruction, that is likely to benefit.
Ben.
Non-obstructive hypercardiomyopathy is, as you rightly said, is something totally different. Without obstruction, there's hypertrophy.
Yes, and the main benefit of these drugs is relief of obstruction, probably.
Right.
And uh, and it's not just hypertrophy. There is myocyte disarray. So the pathophysiology of non-obstructive is much more complex than just hypercontractile heart.
Histologically, are they different?
No, sir. Histologically, they are very similar.
So then how do we say it's different? Is it not that there is hypertrophy in one particular place which is causing different kind of a problem?
So I think in this, the symptoms are due to the obstruction. It is the obstruction that is giving rise to the symptoms. So a person with obstructive hypertrophic cardiomyopathy is much more likely to be symptomatic than a person who's non-obstructive cardiomyopathy.
But Ajay, you have seen people with such severe generalized hypertrophy that there's hardly any space left in the ventricle. They are highly symptomatic with
Yes, sir.
no help to them.
Yes. So,
Can I ask one
Yeah,
question?
please.
yeah, please.
So about this angina in non-obstructive HCM, there was a very small study, I think in 2024 ESC, where they were showing that angina scores were maybe a little bit less with aficamten in non-obstructive situations. So, but that is not the case with mavacamten, I think. So, this angina in non-obstructive HCM patients, can CMIs have a role? Many.
I think
Ajay,
till we
over to
have
you.
the data, I don't think so. I think right now they have a very good role in obstructive cardiomyopathy or hypertrophic cardiomyopathy, but in non-obstructive, probably I don't know. They probably may not have a role even after all these trials are available.
Right. I like this line,
Yes, sir.
beware when standard of care evolves out of practice rather than evidence.
Yes,
Challenging
absolutely.
the
Yes,
status quo is needed for progress in medicine. Very good.
yes.
And
Okay.
also, I'd like to point out that in obstruction and non-obstruction are all dynamic. Sometimes the patient may have obstruction, sometimes the obstruction, extent of obstruction may not be the same. So, what's your take on that? Because
But
hypertrophy
isn't that
sometimes
it is dynamic, but
it is
even
dynamic.
I mean,
Sometimes
the obstruction may be mild or may get aggravated with provocation, but some obstruction is always there, isn't it, Ajay?
Yes, sir. So, in most patients, if we do a maneuver, in two-thirds of HCM patients, we would get an obstruction.
And what about apical heart cardiomyopathy? Is it the same as NHCM or is it different?
Yes, sir. Most will be non-obstructive. Apical, most will be non-obstructive. Only thing
Some
is
of
that
them
in
have mid-cavitary, some of them have mid-cavitary gradients rather than outflow gradients. So in
yeah.
them also will CMIs work?
Ajay,
Uh,
mid cavity
I
obstruction.
don't think we have the data on that, but if we look at the diisopyramide data, it does work in mid cavity, although the efficacy is lower than in classical LVOTO. So
But
hopefully they should work.
if it is obstruction which is causing symptom, then whether you do surgical myomectomy there or do alcohol ablation mid cavity, it should work.
Yes, it works. Only thing is, mid alcohol ablation in mid cavity is a little difficult because identifying the exact septal and the type in a LVOTO, it's very clear that you have to ablate the septum. Whereas in a mid cavity, it may not be the septum; it may be the septum plus a little bit of the anterior wall, the lateral wall. So alcohol ablation is often not that effective in mid cavity. So mid cavity, it's always better to go in for a myectomy unless there's a clear cut septal obstruction.
Okay.
I have one little question. Can I
Yes.
ask? Because I have one patient with hypertrophic cardiomyopathy who underwent a coronary angiogram for some reason and has got a triple vessel disease. So should we stent these lesions or should we let them go because myocardial function is better for them?
If the lesions are significant, you have to deal with that. We have also had a couple of patients like that. I mean, you have to relieve the coronary obstruction and then deal with them medically.
Okay. Thank you.
Sure. Let's go on. So again, next is a very interesting trial again. Vanish 2, catheter ablation or antiarrhythmic drugs for ventricular tachycardias. Again, published in NEJM. So 416 patients, 4.3 years follow-up, and look at this a little. I would like you to concentrate on this. This compared endocardial CA, that is catheter ablation with antiarrhythmic therapy as a first-line treatment, randomized 1:1 either catheter ablation or sotalol or amiodarone. Sotalol in patients with EGFR more than 30, NYHA 1 to 2, EF more than 20, and no history of Tossard, QT prolongation, or VT storm. They had to have more than one of following in the previous 6 months without antiarrhythmic therapy, either sustained monomorphic VT terminated by pharmacological or electrical cardioversion, more than 3 VT episodes terminated with anti-tachycardia pacing with symptoms, more than 5 VT episodes treated with anti-tachycardia pacing, more than one appropriate ICD shock, or more than 3 VT episodes in previous 24 hours. So documentation that there are significant arrhythmias present. They excluded active myocardial ischemia, ACS, PCI recently, VT ablation prior, thrombus, and other things. The principal findings were that the primary outcome, which is a composite of all-cause death, VT storm, or appropriate ICD shock, or sustained VT below ICD detection rate requiring treatment for catheter ablation versus AAD was 50% versus 60%, hazard ratio 0.75, narrow confidence intervals, and the p-value of 0.03. All-cause death very high in both 22%, 25%, hazard ratio 0.85, not reaching statistical significance. Appropriate ICD shocks 29 and 38. Again, confidence interval crossing the line of unity. VT storm 21.1 versus 23.7, no difference. Sustained VT below ICD detection rate requiring treatment 4.4 versus 16.4, which is very significant. Narrow confidence interval. The interpretation was catheter ablation as a preferred initial treatment strategy over antiarrhythmic drugs. Fewer non-fatal adverse events. Overall mortality is high and comparable in both arms. ICD shocks and medical intervention for sustained VT decrease with catheter ablation, may contribute significantly to quality of life. Findings do not extend to non-ischemic cardiomyopathy. In ischemic cardiomyopathy and VT, especially in those who may be at higher risk for AAD-related adverse events or toxicity, catheter ablation alone may be a reasonable first-line therapy. Comments? Anybody wants to say? So what they have tried to say is that catheter ablation is a preferred initial strategy over antiarrhythmic drugs.
So I think it may be very reasonable because we also had a few patients with recurrent shocks, and catheter ablation is very effective in ischemic cardiomyopathy. So again, the same interpretation as what was in the last trial, that practice determines, or whatever is the tradition determines what we are practicing today. So I think if we look at it from a fresh point of view, since catheter ablation is now freely available, it's safe and accessible, probably it can be considered as a first line therapy.
We also do a lot of VT ablations and seems to help a lot. Okay, any other comments or shall I go on?
So only I think this was a predominantly Canadian, it was predominantly, I think, a Canadian population. The expert center, they use high volumes of, they do high volumes of catheter VT ablation.
Right.
Most electrophysiologists, what we only do supraventricular or AF ablations.
Oh,
So maybe that might.
Correct. It has to be somebody who's
Yes, sir.
experienced to do it.
Because
Other centers.
VT ablation one is very time taking, that you have to do a 3D, you have to map it around.
Yeah.
And
Yes.
PSVT is like a angioplasty only. It takes 20 minutes, 15
Yes.
minutes. You are in and you know where to burn and you come out. But VT definitely needs a lot of, and it needs a prior MRI, prior localization of a scar. And then you have to trace out where you have to burn at exit point or at entry point. And failure rates, I feel in my practice that the failure rates are higher for VT. We have recurrence rate which is higher for VT. PHVT is 100% curable, 96% curable. That's a very
And sometimes you may need an epicardial approach also. Not that
yes, sir.
common.
Sometimes
So
we need an
complicates the whole thing,
epicardial
yes.
approach, and it makes the things difficult.
Okay. So since we are running out of time, next is two trials which are extremely interesting, which is beta blockers post myocardial infarction with preserved ejection fraction. So this was two trials published in the same issue of NEJM. Reboot which is beta blockers after MI without reduced ejection fraction, Bitami Dan block, beta blockers after MI in patients without heart failure, both published in the same issue of NAJM. So if you take Bitami, role of beta blockers after MI without heart failure remains uncertain. They combine two national-wide randomized trials from Norway and Denmark. I must tell you that these are the countries where health records are so meticulous. Even if somebody has taken a tablet of aspirin, it is there in the records, and everything can be pulled out. Over 5,500 patients, EF more than 40%, follow-up 3 to 5 years, 95% were on metoprolol. Registry follow-up endpoints adjudicated. Primary endpoint, all-cause mortality or MACE, as mentioned here. Their primary results were that with beta blocker, there was a benefit on a long-term follow-up with a hazard ratio of 0.85 and a narrow confidence interval 0.75 to 0.98, p 0.03. Subgroup analysis revealed that there was no difference across different subgroups: sex, age, country, type of MI, STEMI, non-STEMI, LVEF, beta blocker dose less than 50 milligrams, over 50 milligrams, hypertension, diabetes. Everybody seemed to benefit, some a little bit more, some a little bit less. Conclusions were long-term beta blocker therapy started within 14 days after MI lowered the risk of death or major CV events compared to no beta blocker therapy. In this adequately powered study, beta blockers proved superior to no beta blockers, supporting their continued role in secondary prevention after MI. Key messages as published in NAGM: in a patient with heart attack but no heart failure, long-term beta blockers reduce the risk of death or serious CV events. Results need to be interpreted together with other contemporary trials. Number one. Second is reboot trial, again in the same issue. So they again took is a pragmatic, controlled, prospective, randomized, open, blinded endpoint trial, randomized at discharge to beta blockers or no beta blockers, type and dose decided by physician, hypothesis, superiority of beta blocker, sample size 8,500 patients, follow-up at 3, 15, 36 and 48 months, outcomes adjudicated. STEMI or non-STEMI, EF over 40%, invasive management during index admission, coronary angio with or without PCI. Primary endpoint, incidence of composite of all-cause mortality, non-fatal MI or admissions for heart failure. And these are secondary endpoints which are individual of that, incidence of sustained BTVF. Look at this as compared to the previous trial, zero difference. Beta blocker group 316, control 307, hazard ratio 1.04, no difference at all. And you can see primary and secondary endpoints, there was absolutely no difference. Safety, broad endpoints, again, no difference. Type of beta blockers used, bisoprolol dominantly, metoprolol 309, other beta blockers 273. These two trials were discussed by Dr. Cleland in Heart Failure Association HFA meeting of ESC last year. Very interesting. I was there to listen to them. So he said there are two useful clinical trials. These are large pragmatic strategy trials which mirror decision making in clinical practice, reflecting diverse investigators' opinion, equipoise, and comfort zone. Results should be extrapolated cautiously. The advantage, the things was there was no placebo, low complexity, low cost. There was no commercial support for any of these trials, so they were independent. Are they generalizable? More than 100,000 patients per year in Spain, Italy, Norway, and Denmark. And the enrollment was about 10% of the available patients, which is a significant number. Effect of beta blockers in patients without heart failure, but EF 40 to 49% is as shown here in different trials. In one trial, it is just about statistically significant, but in other trials, it is not significant. So he said, again, this was very interesting. He said, proposed strategy for managing acute MI for those concerned with therapeutic inertia. You start with everything, review after 6 to 12 weeks. Unless they are indicated, you can stop ACE ARB-ARNI. Beta blockers review after 6 to 12 weeks. If anti-proBNP, etc., everything is okay, you can stop unless indicated for systolic dysfunction, high blood pressure, arrhythmia, or angina. Antiplatelet agents also, he says, opinion-based decision to stop. Lipid lowering, influenza vaccination, and lifestyle intervention continue. So these were, I mean, apart from this, two trials, totally diverse results, and large group, nearly 5,000 to 8,000 patients. So what do you people think about these two trials?
I think beta blockers are being neglected now. They're being relegated to the shadows. But I think it's high time we take up isoprolol and other drugs for all patients with myocardial infarction. I mean, I remember the BAT trial, BHAT trial, I don't know, way back in the 90s, I think. What's your impression on that?
So the
Beta.
VHAT trial actually included, I think, atenolol, non-propranolol, the non-selective beta blockers also. And I think the timing of initiation was also not very uniform. Some people were started 2 weeks after. So there are lots of heterogeneity in the old trials also, Copernicus, BHAT. So I think in today's day and age, revascularization is the main thing. So if you can
Yes.
revascularize and the EF improves more than 50%, I think we can take a chance to de-escalate because already there is so much of polypharmacy going on. The beta-mi Dan block actually the difference was mostly because of some reinfarction, 2% I think reduction in reinfarction, which drove the overall slight improvement with beta blockers, which was not the case with reboot. So I think overall the hard endpoints are not affected with beta blocker use.
So, last year I was part of article which was published in Lancet, that is prevention of heart failure after myocardial infarction. This was with Muthaiya Vaduganathan and some of us. There were 5 of us which wrote that article in Lancet. The profile of patients, at least in the West, after MI is changing a lot. Previously, they used to end up with heart failure with reduced ejection fraction. Nowadays, they end up, even if they have heart failure, it's mostly mildly reduced or preserved ejection fraction. Because of early revascularization, the myocardial damage is limited. With that in mind, previously that uniform use of beta blockers probably had a lot to do with a lot of myocardial dysfunction and fall in ejection fraction. Nowadays, once ejection fraction is relatively preserved, questions are being raised.
Sir, maybe I had asked you a similar question when you had presented step heart failure in our discussion only. Like this ejection fraction, say 49% and 50%, 55%, like 45% or 52%, is it very easy to differentiate? Like it might be 48% for me and it might be 52%
Not
for
at all.
somebody else.
Not at all. You're dead right. Is 49% different than 50? Is 50 different than 51? No. It's every day it depends upon the inter-observer variability, intra-observer variability, loading condition, heart rate, presence of ectopics. There are so many things which verify this. Second thing is when you come to mildly reduced ejection fraction, is it a preserved ejection fraction which is getting low or is it a reduced ejection fraction which is getting better? They are two different trajectories altogether. So I think by and large, mildly reduced ejection fraction at the lower end of spectrum, it is likely to behave more like reduced ejection fraction. At the upper end, more like the preserved ejection fraction. And sometime back in a meeting, I asked Dr. Swedberg. We were in a meeting together. I said, "Who defined this 40% or 45%?" He said, "We are guilty," because he said when we were doing the earlier beta blocker trials, we wanted quick endpoints. So we decided 40% below that will be reduced ejection fraction. But now ejection fraction is being questioned. Either it is preserved or it is reduced. And if it is reduced, the lower it gets, there's greater neurohormonal activation and therefore a better effect of agents like ACE-ARB-ARNI, beta blockers, and aldosterone antagonists. At higher ejection fractions, these things don't seem to work that well. Okay, so food for thought. So finally, last trial. I think you must be sleepy, all of you by now.
Mhm.
So last trial, this is FAIR HF2. This is intravenous iron in patients with systolic heart failure. It was presented last year in Heart Failure Association meeting of ESC. So there have been a number of trials, and they at present iron estimation occupies a class 1 indication, and iron treatment occupies class 2 treatment, which again is something that I asked in one of the guideline meetings of ESC, that if estimation is class 1, why would you have treatment as class 2? So there was no answer. So anyway, so this was a multi-center randomized trial, 1,100 patients randomized to two groups: symptomatic CHF with EF less than 45, HB 9.5 to 14, established iron deficiency, currently hospitalized and considered restabilized, or stable ambulatory BNP more than 100. So they were followed up, and the primary endpoint was CV death, heart failure hospitalization, recurrent CV events, and results were a little bit disappointing, slightly different. If you take at 12 months, the uh, result was significant. Towards the end, it was not significant. And same thing held true for first and recurrent heart failure hospitalizations. The primary endpoint in the subgroup of patients with TSAT less than 20% at follow-up, at 12 months, all these results were significant. As time went by, the results became non-significant. But the summary was heart failure hospitalization reduced by 21%, recurrent heart failure by 20%, secondary endpoints, improvement in quality of life score, self-reported uh, outcome improvement. So conclusions were result of FAIR HF2 in terms of impact on mortality and morbidity events are highly consistent with those of AFFIRM HF and Ironman, but do not reach statistical significance. Suggests that both classical iron deficiency, including ferritin or a simplified one, are useful. FAIR HF confirms the benefits of iron therapy on quality of life and patient self-reported health status. So this was presented last year in European Society of Cardiology Heart Failure, and I had the privilege to be giving expert comments on this on the stage. The trial was done during COVID period, so there was a lot of delay, lot of dropouts, which probably impacted. But and the other thing was that the first dose which was given was full, but subsequently many patients did not receive iron, did not receive a full dose. Whether that impacted or not, we don't know. But as it stands, so far the evidence is that there's no benefit in mortality, but it has benefit as far as the reduction in uh, hospitalizations and quality of life. Do you people use IV iron or?
Yes. So,
Only in patients with iron deficiency anemia, we use them. But in
uh,
heart,
So
sir,
this is what I had to present. I
yes.
hope I was trying. I'm sure there were a lot of trials which got missed out, but
Yes.
that in the limited time, I tried to choose provocative trials and something which I found interesting.
So, as far as subjective improvement is concerned, if the saturation is less than 10%, then the patient really feels better in 2 to 3 days. Whereas if it's between 15 to 20%, although it is iron deficiency, probably the patient may not have so much of benefit. So, I think although we define as 20%,
Hmm.
I think the patients who are actually less than 15% are the ones who really benefit.
So the greater the deficiency, the greater is the
Yes.
benefit.
Mhm.
Okay, Sojatya,
Yes.
I hope
Thank
Thank you so much, sir.
that
I
would
think
be
make
yeah,
it
wonderful
a little.
news.
I
All
thought let me involve everybody, so I hope you
uh,
didn't find
I
it too
learned a
boring.
lot.
you.
I learned a
Thank you,
lot.
sir.
no,
Yes.
absolutely not, sir. It was,
Thank
we found it very educative. So you rightly picked up all the controversial or the trials which are mostly in focus. So it was great, sir. Uh, Going forward, what do you think, sir? Just as a general comment, maybe like for students or for people like us in cardiology who are like getting into this. So how do we we are not oriented towards interpreting trials or reading trials. We just go by whatever the conclusions are said. So how do you feel? Should this be there? Some
I think
should
for
be there.
students it's very important for them to understand statistics, because you cannot critically analyze a trial unless you understand statistics. So we should get one of the cardiologists who's good in statistics to take some classes for them. Not only for them, for us also. Everybody. And second, maybe after every major cardiology meeting, say ACC and ESC, there can be a session in which the major trials which have been presented in that can be analyzed, because then you can have a much wider selection, and in a year if you have 3 or 4 meetings like this, you can analyze much more trial, and that brings you up to date with whatever is happening in the world.
Unfortunately,
Absolutely.
statistics are not taught.
Yeah, I think, Sajatya, we can have a journal presentation kind of thing in our this thing also, and you can have the 10-15 minute discussion with 4 people speaking on different trials.
Yeah, bilkul.
Actually, sir, like I had suggested, maybe 6 months. In 6 months, one topic. At the end of 6 months, maybe there should be one presentation on journal club, like reviewing the
But
few salient trials.
after each major meeting, if a summary of that meeting can be given, that I think is very educative. Not everybody can go,
Yes.
not everybody watches all the sessions being presented. But like actually what you can do is at the end of each meeting, there's a summary of the that meeting which is presented by somebody or the other. You can take a recording of that and just play it. So intervention, heart failure, hypertension, dyslipidemias, there are 15-20 minutes presentation for each, highlights of the conference. In 1 hour session, you can play 4 of them, and that kind of sums up the whole conference.
Absolutely, sir. Absolutely. No, I think Smith sir was talking about what we can do in our PGI masterclass thing. I think if we can have these journal clubs more frequently, discussions of journals, critical analysis, it will be helpful for all of us.
Smith,
So
why have
when
you
we
turned off your video?
Sir, I'm in a car, sir.
No, we can still, that's okay.
Hmm.
Even faintly visible, you are very useful.
Yes,
Okay.
sir.
Chalo. Okay then.
Thank
Good night,
you. Thank you, sir.
everybody.
Thank you, sir.
Thank you,
Thank you.
sir. Good night. Good night.
Smith, I will call you. I have to discuss something with you.
Sir, sure, sir.
Okay.
Sir.
Okay.
Thank you so much,
Good
sir,
night,
for.
everybody.
Good night. Good night.
Thanks. Thank you, sir.
Yes.
Bye.
We can stop recording now. Yes.
Bye, Soja.
Good night, sir. Thank you,
Good
sir.
night.
Bye, sir.